Dear all, critical evaluation of drug promotional literature is an important exercise for the phase 2 students in pharmacology, and it is certifiable. Therefore, I have prepared a presentation for session technique and for understanding how it is to be done. The competency domain is skill, level is perform. That means student has to perform it because it is a core and requires certification. Therefore, at least 3 times he or she has to perform, that is fill the given pro forma during critical appraisal of drug promotion literature. The suggested teaching learning method is demonstration followed by skill lab performance or skill stations. The time required is 1 hour for demonstration and 2 hours for 3 sessions, each of 40 minutes. Means each student would get 40 minutes to fill one pro forma, and this way either during that entire time or at different times he has to perform 3 times. Appropriate timing of this exercise should be at the beginning of 4th semester, because by that time students would have learned generally autonomic nervous system, CNS, PNS, respiratory and or cardiovascular pharmacology. They would have also attended a number of clinics, so they are now oriented. Evaluation for certification has to be done by direct observation and checklist. Now let us understand drug promotion, meaning and impact. Drug promotion refers to all informational and persuasive activities by manufacturers and distributors, the effect of which is to induce the prescription, supply, purchase and or use of medicinal drugs. Now here students should be explained what does it mean to be persuasive, what does it mean to induce, and what does it mean to prescribe. Now prerequisite for these promotion activities are: all promotion making claims concerning medicinal drug use should be reliable, accurate, truthful, informative, balanced, up to date, capable of substantiation and in good taste. They should not contain misleading or unverifiable statements or omissions likely to induce medically unjustifiable use or to give rise to undue risk to the patient. But safe should be used cautiously and provided it is properly qualified, because safety is a relative term. Comparison of products should be factual, fair and capable of substantiation. Promotional material should not be designed so as to disguise the real nature of the end product. Expenditure on drug promotion by industry is done in many ways. To promote the activities, they give free samples, free gifts, tinkles, pen, tabletop and something like that, sponsorship, travel grant, stay and sightseeing and cash incentives. Ghost writing, they will write an article, they will give the name of the prescriber and therefore it will do well. Funding for development of treatment guidelines and monograms is also done. Drug promotional literature is of many types actually, and most common is the brochure or product information sheet for new and old drugs, which is often left by the medical representative after detailing. There are also follow-ons and reminders which are of smaller sizes. Advertisement in medical journals, monograms, guideline documents, quizzes, crossword puzzles with prizes and medical humors are all the formats for drug promotion. And the printed expert opinions and case discussions are also increasingly used. See, this is an example of how a monogram of their product is made and distributed, and how guidelines already established for, such as for nebulization, are printed and stimulated. Now, for interns and residents and for many busy doctors, Drug promotional literature becomes a hidden curriculum because they have hardly any time to read in length, and they are dependent on the briefs provided by the drug industry and medical detailing representative. Often DPL remains the only source of information to them, and therefore interns and residents subconsciously learn that drug promotional material provided by industry is a rich source of learning about drugs and therapies, and sponsored CMEs and acceptance of freebies are accepted as norms in medical profession, and one develops inaccurate beliefs about DPL, a behavior conducive to industry motives. This promotes irrational drug use and increases cost of. WHO has laid criteria for the drug promotion literature, and these criteria are laid in 1988 as ethical criteria for drug promotion. The promotional claims should be true, reliable, informative, balanced, updated, and have authentic information. This is the nutshell of the document, and details we will be discussing. The minimum information to be provided on DPL on a brochure is 11 point given here, which would include about the name, about the contents, about the uses, about the regime, about the adverse effects, precautions, contraindications, interactions, manufacturers, name and reference. Reminders which are given is a small brochure or advertisement paper. It should have brand name, INN, ingredients and name of the manufacturer. These reminders are used as reinforcers to prescribe. Now WHO has also prepared a sample drug information sheet with very major 4 points. One is regarding INN, second is regarding pharmacological data, third is regarding clinical information about indication, dose, dosage form, dosing interval, average duration and use in special. Point is contraindication, precaution, warning, adverse effects, drug interactions, overdose. Pharmaceutical preparation should also be in details in the form of type of the dosage form, strength in each dosage form, capsule, tablet, liquid, whatever it is, excipients, storage condition, pack size and description of packing, and its legal category, mostly drug schedules such as schedule H, A, B, C or X, whatever it is, and name and age of man. Now, so how we should evaluate a DPL? Evaluation of text, evaluation of pictures and images, evaluation of data and graphs, and evaluation of reference. For each, there are recommendations available. The salient features for evaluation of text is the ratio of generic to brand name font size. It is said that drug and cosmetic rule allows generic name should be 2 font size larger than the brand name, which is usually not done by the industry. Are the claims restricted to clear clinical outcomes or meaningful economic gains? This we have to evaluate. Are the claims for safety, efficacy, cost effectiveness backed by adequate level of evidence? Is the claim for use in a specific population supported by high quality evidence? Is the information about safety given same prominence as given to efficacy? Is the cost price given exactly or just as costs less? Is the advertisement for antibiotic use according to the published guidelines, or they are because of? Now we can also evaluate images and pictures in drug promotion literature. Are the images and pictures relevant to the drug or drug use? Are men and women portrayed as patients in equal number? If symbols or metaphors are used, then what kind of association do they have with the product? Are illnesses or diseases revealed as individual events or social contexts? Are pictures of celebrities used to show? We can also analyze data and graphs scientifically. Is the information just given, or it is given as relative risk reduction, absolute risk reduction, or number needed to treat? Because these are the quantifiable data actually. In a study, is a study quoted? Then was this study blinded or randomized? So detail of the quoted study should be there. If stats are used, then is the power of study and confidence intervals shown? Are graphs appropriately labeled on X and Y? We will see that how distortions occur. Are graphs simple and clear to comprehend, or they are morphed to exaggerate the effect? If they are taken from another study, are they depicted as such or changed? Are given data clear to comprehend? Mostly, company DPL shows data on file. We would like to know what this data. Even references can also be analyzed. Citations from type of the citation, and they are traceable. They are of high methodological quality references. The journal references come from peer-reviewed, indexed medical or pharmacy journals. Or did the company finance because conflict of interest is there? So the research project and referred reference was financed by company, then outcome has to be different. This is one just advertisement, maybe follow on as well, because very little is given. Assured control, use of superlatives like assured control. What assurance is there? What does this image mean? Note the size of generic and brand names. Percentage reduction, risk reduction is not there. Only reduction in the MACE points in the current MI. So this is a usual story. This yet another one. They say penetrates ensures success. Penetrates what? And what makes links the ideal first line of treatment? The real term should be what makes lincomycin as the real first line of drug. But this is how the changed lines are used by them. Even this pictorial of graph is not very clear, and there is a certificate showing Wallace innovation which is as big a size as graph. So they have compromised graph size for this pictorial. Even you can see incomplete references, illegible, not even clear. So how do we gather information and evaluate from an advertisement in medical journal? Name, INN, approved generic name, active ingredient in dosage form, dose regime, additive or vehicle which is used, approved therapeutic uses, side effects, major adverse effects, precautions, contraindications and warnings, major interactions, name and address of manufacturer, references and inclusion of irrelevant. So now we can conclude this way that inclusion of flawed information, omission of relevant information, distraction with irrelevant information are the three major categories of how there are DPL are formed and circulated. Now I'll cite one study, three studies. Study 1 is from Ganashri in 2016, and what they found, they analyzed 200 DPL according to WHO criteria. Only half of the DPLs fulfilled WHO criteria. Unsubstantiated claims about efficacy, safety were found in brochures, and those claims were also therapeutically irrelevant. References were not up to the mark, they were old. Exaggeration was there, highlighting positive outcomes without limitations. Drug cost was shown in only 6% cases. Larger space was given to visuals. Only 32% had pictures relevant to product. Pharmacological properties were represented in 29.5%, and ADR, precaution, contraindication, interaction in less than 40% cases. Yes. Almost similar things happen in study 2. Here we see that 393 out of 543 collected DPLs were analyzable, and approximately 70% of DPLs met only half of the WHO criteria. Pictures were relevant to 22% DPLs, cost was mentioned in 25.7%, and precaution warning contraindications were given in less than 30% cases, and references from PubMed journals were 40% only. In this study 3, which is online published in 2023, 191 DPLs were analyzed from tertiary care center, and results were that even clinicians are not aware about the WHO criteria of evolution. Only one-third of the clinicians could respond this way. And among the WHO criteria, therapeutic uses were mentioned in 60%, references in 15%, ADR in 17%, contraindication precaution 14%, and cost in 11% of the literature. Even differential advertisements are done in developed countries and developing countries. Contraindication warning side effects are given less often in developing countries than in developed countries. Visual misrepresentation is quite common. If you see actual, it is only 94 and 95% difference, so a difference of 1%. But actually what they show is very larger picture of 95% by enlarging the upper portion only. They are getting the lower portion at all. So difference appears to be double, which is actually not. Even numerical distortions is done. Now look at the age bracket of 70 to 74. Here we see that probably death rate in male and females are more or less same. But actually it is not same, because y-axis is logarithm axis, and the males, 2000 males die, whereas 1000 females die. So this is a visual distortion by changing the log scale. Now types of the claims which are made in DPL, mostly they talk of efficacy, safety to some extent, but cost less than 30%. Kinetics almost less than 20%, and pharmaceutical properties to the. Now earlier I spoke about the free samples and heavy expenditure done by the company. Now impact of free sample on prescribing is just one example. When samples were not available, 61% prescribers used first line drugs in hypertension. But when samples were available, 62% prescribed second line drugs in hypertension, and that is irrational prescribing and done by providing free samples. So critical analysis of drug promotional literature is of paramount importance to avoid irrational drug use and practice evidence-based medicine. And therefore all students by now must have understood the need for critical. A format which I have prepared from the criteria and the format given by WHO is the 14-point format. First, second are names. Third is whether it is a fixed dose or single ingredient. Fourth is pharmacological actions mechanism. Five is clinical information. Then that includes all the points which. Sixth is pharmaceutical information. Additional points are check the proof of claims in advertisement, references, use of superlatives, extravagant emotional phrases or exaggerated claim, relevance of pictorials, graphs to the drug, stats analysis, name and address manufacturer, address of further information, any other additional information given, and completeness of the items as per WHO. When a student fills all these, then it is easier, he can actually understand the drug promotional. Now session techniques. To conduct this session, we need to collect DPL from various systems, various diseases involving different body systems, and mostly they are available because the representatives leave it with the doctors, they don't use it again. So large number of them can be collected, then selected, carefully selected, that's very important for teaching. Now a batch of 30 students, 15 to 30 skill stations can be made according to the availability of staff. One DPL per station, one student or two students can work per station. There will be 3 to 5 observers. Every student shall fill independently the appraisal sheet for 3 different DPLs in the same time or at the different sessions. Certification is required to be done, and for that direct observation and a checklist for evaluation is to be filled by observer. This is the proposed format for checklist, which any medical teacher can modify by cooperative efforts. Careful, and these checklists will be observation and evaluation of the sheets. Carefully reads the DPL, highlights size of generic and brand names, identifies exaggerations and omissions, identifies stats information and its interpretation correctly, seeks help from peers or tutors or fills independently, writes comments also and completes all entries. Now, he may not be able to do during session 1, but may be able to do second 3, and by the third one he will be able to do independently, and that means it can be certified. So this is the way we can teach and train the second MBBS student to critically evaluate drug promotional literature.